Okay, Assalamu alaikum everyone again. So it falls to me to talk about malignant pleural effusion, and once again, my apologies for not being there in person. So what we will talk about in this particular talk is pleurodesis and the relative evidence, indwelling pleural catheters, combined procedures, and then new directions and also guidelines. And I guess one thing that's important is this talk will focus very much on the respiratory physician treatment of malignant pleural effusion, as opposed to the important diagnostics that we, of course, as respiratory physicians also do. You've had a very good talk already on the approach to the undiagnosed effusion that will, of course, include pleural biopsy, CT-guided biopsy, CT assessment, ultrasound assessment. So I won't touch anything to do with those. We'll focus purely on treatment. And I guess the other thing to say in this area, rather excitingly, is that there is now good quality evidence to guide us exactly what to do best. And it's important we understand that evidence. These are six of the largest publications in the biggest journals in the world, actually, in the last 10, 15 years, that have directly addressed issues on how we should manage patients with malignant pleural effusion. And I'll cover these in my talk over the next 20 minutes or so. And this proliferation of studies has resulted in updated guidelines, and rightly so. So this is Anna Bibby's guideline from 2018 in the European Respiratory Society. This was followed some months later by the American Thoracic Society guideline. The ATS guideline came with an algorithm, a treatment algorithm, whereas the 2018 ERS guideline did not. And this is what the ATS guideline suggests. So it asks us to look whether the patient is symptomatic, do they have improvement in their dyspnea having been drained, and do they have lung expansion as a key decision-making point. And at this point, we're then asked to discuss the relative risks and benefits of IPC or pleurodesis or combination, and then it sends us down the algorithm here to either talc poudrage or slurry, or consider placement of an IPC. And we'll talk about the relative risks and benefits of doing that. So let me go through some of the data. Firstly, pleurodesis still remains an important treatment, and therefore we should consider what's the best way of you and I as a physician conducting optimal pleurodesis. And this study, which is one of my studies from Oxford, I think addresses that directly. So in this particular study, time one, we were asking two questions at the same time. The first, I was taught, certainly as a trainee, that using non-steroidal anti-inflammatory drugs were not allowed when you were doing a pleurodesis because they're anti-inflammatory and therefore impair pleurodesis. Non-steroidals are an extremely effective painkiller. In fact, in the acute phase, they're much more effective than opiates, and yet we avoid them in pleurodesis. When we looked into the data, this statement that we shouldn't be using them in pleurodesis was based on 3 animal studies only. So there was some uncertainty about whether we could safely use non-steroidals. And then secondly, what size of chest tube should you be using for your malignant effusion pleurodesis? Now, most physicians have moved towards the smaller bore drains, so 14 French and less. Most surgeons still use the old-fashioned 24-28 drains. They happen to be inserted with a different technique, one guide wire and one blunt dissection. But the question really is which one is more effective, or are they exactly the same? If we go back to the 2010 BTS guideline, they cited one randomized trial which appeared to show no difference between small and large bore drains, but it was horribly underpowered, only 18 patients. And although they said and reported a similar pleurodesis rate, their confidence interval for the difference was enormous because it was such an underpowered study. And therefore, it hasn't really been answered which drain is best for a malignant effusion pleurodesis. And hence we did this study just to explain. We took 320 patients who had MPE requiring a pleurodesis, and we randomized them twice, which is called a factorial design, either to large bore drain or small bore drain, and then a second randomization to either high dose non-steroidal in hospital or opiate in hospital while they had a tube in place. We then pleurodesed them, and we were looking at 2 outcomes. One, how much pain did they experience during their treatment? And 2, what was their pleurodesis success rate like at 4 weeks and 3 months? And this is what we showed. So on the left-hand side, these are both pain scores, by the way. On the y-axis is pain out of 100, with the top being very painful, 0 being no pain. So this is the chest tube comparison, and this is the opiate NSAID comparison. You can see here that the larger bore chest tube is consistently more painful all the way through treatment. So this is hours since tube insertion. It was obviously variable because some people had it removed before. But interestingly, although it is more painful, especially at the very start of insertion, overall, there was a statistical difference, but this difference is relatively small, so about 5 or 6 millimeters on the 100 millimeter scale, which is not clinically significant. And then if you look at opiates and non-steroidals, actually at the beginning, the non-steroidal resulted in the first 8 hours in significantly less pain in that first 8 hours, but overall there was no difference in pain. But if we look at the likelihood of pleurodesis success, so this is a survival graph, Kaplan-Meier, of months since their pleurodesis, and this is pleurodesis success rate. This should read success, not failure. You can see the non-steroidal and the opiate is exactly the same. And at 3 months, we have an 80% success rate with pleurodesis, regardless of whether you use high-dose non-steroidal in hospital or whether you use opiate. This tells us that it is safe to use non-steroidals. However, I was not expecting this outcome, but the 24 French strain is in fact more effective than the 12 French strain in pleurodesis success. So at 3 months, there's an approximately 10% difference between the two, favoring the larger bore drain. So I had assumed that the small bore drain would be just as good. In fact, 24 French is more effective in pleurodesis, and we think that's because the smaller bore drains become blocked and become dislodged a bit more frequently than the larger bore drains. So on the basis of this study, at least, if you want to do the optimal pleurodesis, you should probably, well, you can use either non-steroidals or opiate. There's no problem with either. A large bore is more effective for pleurodesis. It's slightly more painful, but in my unit, when we choose to do a pleurodesis, we now use something bigger than a 14 French drain. Let's talk about optimal talc delivery then. You will all know we have several options, so we can give it as a talc slurry at the bedside. That's obviously simple and straightforward to do, but this is at least said to be the more effective method. So this is a medical thoracoscopy, two-port technique, and you can see that we have a stiff trocar in here, which is being used in order to spray the talc in, which is called a poudrage technique. And the received wisdom is that this creates a nice, unified, similar layer of talc in a dry pleural space, and therefore it must be much more effective. Unfortunately, the data historically anyway, this is the Dresler study from the USA some 20 years ago. This was an American study looking at VATS insufflation versus talc slurry at the bedside. And you can see, in fact, there's no difference in pleurodesis success whatsoever. Once again, getting to a success rate of 60 to 80%. But there was a problem with the study in that they lost a great deal of patients during follow-up. So some questions remained whether we knew whether poudrage or slurry was more effective. And onto that came this study. So this is a study done by the Bristol group with our support as well. So this is Nick Maskell's study, the TAPS trial. And in this study, what did they show? Exactly the same thing. That's slurry and poudrage. This is well conducted, very little data loss, as you can see. And the overall success rate at 2-3 months is about 80%. And there is absolutely no difference between the two techniques. So we now have 2 randomized trials. Both of them show no benefit of poudrage over slurry, and therefore you can use either. Now, I still do poudrage when I'm doing thoracoscopy, but only if they're having a thoracoscopy anyway for diagnostic reasons. So pleural biopsy and then talc at the same opportunity. Should you take somebody with an established malignant effusion who doesn't need a diagnostic biopsy and say you should have a poudrage? The answer to that is no, because of 2 randomized trials. So we shouldn't be preferring poudrage over slurry. Now, this used to be said to me back in my training days. So stop messing about. You're just a physician. If your silly talc has failed, then we need to do proper surgery to sort it out. So stop messing about. Send it to the experts who are the surgeons. Is there any data on whether surgical pleurodesis or medical pleurodesis is better? Well, we do in fact have one randomized trial, and that is this study called the MESOVAT study. It is limited only to patients who have had mesothelioma, and that should be noted. But nonetheless, this study randomized patients 1-to-1 with mesothelioma to either physician simple talc pleurodesis or a VATS partial pleurectomy. So a VATS pleurodesis versus a medical pleurodesis randomized 1-to-1. Slightly bizarrely, they were looking at survival as the primary outcome, but they also had pleurodesis outcomes in there as well. And to summarize, there was no difference in survival. VATS was longer in hospital, more complications, more expensive, and there was no difference in fluid control or in quality of life. And this is 1-to-1 randomized data that suggests that the physician is just as good as the surgeon in malignant pleural effusion. We admittedly don't have that data in all of malignant pleural effusion, but we certainly have it in mesothelioma. So you should probably avoid surgical pleurodesis in mesothelioma, and there is I think, an argument that we should avoid it in malignant pleural effusion as well. Now, what about this? Choosing talc or IPC. This is bedside slurry talc on the right-hand side here. This is the indwelling pleural catheter that I know they'll show you in the skills lab tomorrow. So just to explain, it's got a one-way valve on the end, an external piece of plastic. My patient is here with his arm up facing to the right. So this is his sternum over here. You can see the radiotherapy tattoo just there, and the failed previous thoracotomy for resecting his lung cancer. He had recurrent effusion, it was malignant. So we've placed the catheter. It has a subcutaneous portion with a dacron cuff just in here that grows into the skin, and then the stitches can be removed about a week later. And this can then be used for recurrent pleural drainage in the home situation. When this first arrived on the scene about 20 years ago, it was hailed as the answer to everything in terms of malignant pleural effusion. No time in hospital, no failure rate, stick the drain in, get them out. It's all very easy. Patients obviously will prefer it. We now have two randomized trials that directly compare those two treatments. Time two trial was from my unit, and then the Ample trial some years later was from the Australian unit, essentially exactly the same methodology. And both of them show the same thing, which I'll just summarize in a couple of slides. Both of them looked at IPC versus talc. Both of them looked at patient-centered outcomes, breathlessness, time in hospital, repeat pleural procedures, and complications. And this is the time 2 outcome, looking at breathlessness. This was breathlessness on a 100 millimeter scale. So down here is better, up here is worse. And you can see that our patients, on average at 6 weeks, have breathlessness scores of about 20 out of 100, and it's the same in talc and IPC. So absolutely no difference between the two. That means that you cannot say that this one, although it's a newer, more interesting treatment perhaps, you can't say that it's better for the patient than talc in terms of breathlessness. I would point out that you are going to make the patient feel much better. So suitable to my first talk on physiology and symptoms, these patients presented with a breathlessness score of over 70. And so by treating them, you're making them feel enormously better. So you're reducing breathlessness by 40 or 50 millimeters, which is an amazing amount, but there is no difference between the two treatments compared one against another. And this is the Ample 1 primary outcome. So their main primary outcome measure was time in hospital, and they demonstrated with a positive p-value that IPCs save time in hospital. And obviously they do, because you implant them and you send them home. With pleurodesis, we admit them. The total amount of time saved in the patient's remaining life was only 2 days. So 2 days, 10 days here versus 12 days for pleurodesis. So the amount of time gain is very modest. And again, in this study, there was no difference in breathlessness. However, in both studies, there was an excess of adverse events, odds ratio 4.7, in IPC patients. And these were largely IPC blockage or infection, as you would expect, because the patient goes home with some plastic in their chest. There were, as I've said, a significant adverse event rate in the IPC patient. So you save time in hospital, but you buy it at the expense of increasing complications. So if we summarize, no difference in quality of life or symptoms, reduce hospital time with the IPC. We reduce pleural procedures using the IPC because you don't have the failure rate, but you're buying those positives with an increased adverse event rate with the IPC. Let me just look at this though. Do we truly reduce further pleural procedures? That's what we tell patients. You have the indwelling catheter and you don't need any further pleural procedures. I think this is a very physician-centric outcome. Let me explain. Both of those two studies suggested that IPC reduces further pleural procedures by about 16 or 18%. So it sounds pretty impressive. But when we look at the normal treatment algorithm for patients with IPC, most patients drain themselves at home or with a carer or with a nurse 3 times a week, and they do so on average over 6 months. Now, if you do the numbers, that equates to 60 or 80 further drainages. So it doesn't really reduce further pleural procedures. It just means those procedures are not in hospital with you. They're done at home. So I think IPCs are great, but they do have some downsides, and it is a lifelong commitment for our patients in general. Now, let's look a little bit further, more IPC interventions. Once we've got the IPC in, maybe we can do even more to the IPC. And onto this comes the silver nitrate study. So we were part of this study, but it was driven by colleagues in the USA. This was really clever. It was an indwelling pleural catheter, and into the indwelling catheter, they embedded silver nitrate as a pleurodesis agent so that when you implant it, it slowly releases the pleurodesis agent and the patient drains themselves. Seems like the best of both worlds, doesn't it? That you're going to drain regularly and you will also get a pleurodesis. So this was a one-to-one randomized trial of normal IPC versus the silver nitrate embedded IPC. And unfortunately, it was a completely negative study with an extremely poor pleurodesis rate. So this is the 3-month rate here. You can see the silver nitrate had a pleurodesis rate of 20% and the IPC had a pleurodesis rate of 35%. Total negative, not worth pursuing, so we won't do that any further. But now let's look at this study, which is the latest study in the literature called Optimum. So this was a great study done by my colleagues in London. We weren't part of this study. And in it, they did another IPC versus talc pleurodesis study, 142 patients. Important bits to say about the IPC is that this was like the IPC arm on steroids. So they did manometry guided drainage, they did an ultrasound post drainage, they gave talc through the IPC as an outpatient, they did daily drainage, and then they removed the IPC if ultrasound was suggestive. So I would argue that this was the most aggressive IPC management you could possibly think of in the world, and they compared this to simple, friendly, old-fashioned talc pleurodesis with a primary outcome, very importantly, of quality of life, because obviously we're trying to improve the quality of life of our patients. What did they show? They showed no difference in quality of life. So we are improving. This is higher on the global health status is better quality of life. At baseline, they have a pretty poor quality of life, and we do improve people's quality of life at 30, 60, and 90 days. But there is no difference between the two. And you can see that it crossed the MCID. So we are making people feel significantly better with our interventions, which is a great blessing. But we're not, one is not better than the other. Not only that, but so this is the change in health status, so no difference in the change in health status. Breathlessness scores, no difference in the breathlessness scores. Chest pain, no difference in chest pain, but pleurodesis failure was enormously different. So if you look here, this is the IPC arm, they had a 64% failure rate versus only an 18% failure rate. And therefore pleurodesis is incredibly successful, and despite the IPC being very, very aggressively managed. And once again, there was an excess of adverse events in the IPC arm. So a very consistent message coming across that IPCs and talc both improve your breathlessness, but IPC has worsened side effect profile, however, does save you a little bit of time in hospital. So this is where I am with IPCs, 3 RCTs, no symptom or quality of life benefit of one versus the other. Both of them improve quality of life and symptoms, higher complications with IPC, and talc versus IPC, talc has a much higher rate of pleurodesis success. Let me then just mention this, talking about the IPC journey. So IPC is a good treatment. I'm not sure if they're available in Iraq as yet, but nonetheless, they're a good treatment, but they're not risk-free. So this was an analysis that one of my colleagues did, Rachel Ashiak. She looked at 180 of our patients who had IPCs for malignant pleural effusion, and she simply followed their clinical records until they had died to understand how much contact they needed with medical services outside of normal drainage. And the answer is 1 in 3 required an urgent further review because of a complication, and the median number of drainages was nearly 100. So that's my point about this is not a drainage-free life. We've just asked the patient to do the drainage instead of us. Now, if you're going to use IPCs, we've got good data on what to do once the IPC has been placed. So there are these 2 randomized trials, this first done by Momin Wahidi, who was a colleague working at Duke in the USA at the time, and then exactly the same thing done some years later by the Australian group. And what they did here was they randomized patients to an IPC and then either drainage in response to symptoms. In the UK, we do it 2 or 3 times a week, or every single day drainage in order to drive a dry pleural space and to drive pleurodesis. And both of the studies show exactly the same thing, which is in the aggressive drainage arm in red in both cases, you double the pleurodesis rate by aggressive drainage. But I just point out that even with aggressive drainage, the pleurodesis rate is only about 40% versus 10 or 20% if you don't use aggressive drainage. So if you place an IPC, if the lung expands, it is worth draining them daily if you want to achieve a pleurodesis and then remove the indwelling catheter. And then we have this study, which has been described as the best of both worlds. Great work from the Bristol group by Rahul Bhatnagar, who led this area. And this was basically saying, look, we've got talc, we've got IPCs. Why don't we give talc through the IPC and do a randomized trial? And that's exactly what we did. So we took patients, we randomized them to inpatient talc, or sorry, not inpatient talc, IPC, all of them, drained for 10 days, fully expansile lung, and then we either gave them talc or we gave them saline, looking at pleurodesis at 5 weeks. And once again, you can see that the addition of talc doubles the pleurodesis rate. What we learn, therefore, is that you can deliver talc as an outpatient. It's safe. It seems to be more effective than saline, giving you an overall pleurodesis rate of about 45%. Now, when this study was published, people said, well, we don't need inpatient talc anymore because we'll just give it through the indwelling catheter. I think that's an enormous mistake. I'll show you why. On the left here is a pleurodesis inpatient study, TAPS. On the right is the IPC plus study that I've shown. If I highlight exactly the same time point in both studies, so that's here and here, so approximately 3 months, you can see that the pleurodesis rates are magnificently different. 80% with inpatient talc, only 55% with outpatient talc. And the IPC plus patients only took on patients with fully expansile lungs, whereas TAPS, it was undifferentiated. So if you want to achieve a pleurodesis, then still old-fashioned admission for a chest drain is the best way of effecting a pleurodesis. Now we've tried to take this even to the next step, which is more efficiency in the system. You would have heard about thoracoscopy for biopsy to achieve a diagnosis. Why can't we do a thoracoscopy, do a biopsy, insert talc at poudrage and put an IPC in all in one go and sort of make the whole thing a one-stop shop type treatment? There are 2 retrospective case series on this, one by Raja Reddy, published in Chest nearly 14 years ago, and then the other by Boujard, published 10 years ago. Both of them quite small, both of them showing that there appears to be a very high success rate, 92%, and then up here, 92%, and they were able to remove the IPC after just a week. It all looked really amazing. This is a retrospective case series, so it is obviously biased. And myself and Nick Maskell have just finished this study. So this is the tactics study where we have randomized patients with symptomatic MPE to either talc poudrage pleurodesis or talc poudrage pleurodesis plus an IPC. And we are looking at pleurodesis success, repeat pleural procedures, and also patient-reported outcome measures. We hope to have results at ERS in September of this year. Just show you what that looks like. So this is at thoracoscopy. This is the splittable introducer. We're introducing the IPC under live direct vision, and then this is what the wire looks like when we're inside. So it's a very easy technique to use if it is shown to be helpful. So pleurodesis remains important, and I'll just make this final point about optimizing the pleurodesis pathway, and that is using ultrasound as what I call the theranostic tool. So the problem of pleurodesis is really the time spent in hospital after it is done. It's very successful when it's successful, but we have to wait in hospital for quite a few days, and therefore we were looking at a novel way of achieving pleurodesis, and this is something that you may, with the correct ultrasound skills, be able to embed in your own clinical practice. So what we did is we took 300 patients who had malignant pleural effusion who required a pleurodesis. We randomized them to standard post-pleurodesis care or thoracic ultrasound guided management. And we were looking at how long they stayed in hospital and how successful the pleurodesis was. Now, standard post-pleurodesis care was the BTS guideline at the time, which suggested that after a pleurodesis, you do a chest x-ray, you measure the pleural fluid output, and if it is less than 150 mils per day, you can withdraw the drain. If it's not, you keep the drain in and you keep doing x-rays. When we looked into the data that was based on, it was one very small retrospective case series. So it seemed to us that this was probably an old-fashioned way of doing things. So we decided to look at ultrasound guided management. So bedside thoracic ultrasound guided management as opposed to chest x-ray and fluid output. And this is what we did to the patients in the intervention arm. So on a daily basis, we scanned them in 9 thoracic positions. So 3 posterior, 3 anterior, and 3 lateral on the side of the pleurodesis. In each position, we scored their ultrasound as to whether there was lung sliding present, which is a surrogate for pleurodesis, we think. And so the lowest possible score, meaning it's sliding everywhere, was 9. The highest possible score, meaning no sliding anywhere, was 27. And if they had a score in the whole thorax of greater than 20, we encourage removal of the drain, hence ultrasound guided treatment. This is what that looks like, just for those of you who don't do ultrasound. So this is a B mode up here. This is an M mode, which is simply the B mode, but with time along the x-axis. So you can see this thing here is the parietal pleura. Here is the visceral pleura. Here is the parietal pleura. And as the patient breathes in and out, you can see lung sliding, and you can see that on this graph here. This is the so-called seashore sign. So here's the sea, here is the shore, and you can see that there is clear movement. Now, this was a patient who we just drained the effusion from. We then gave them talc pleurodesis. What happens next? The next day, you can see that there is no movement, the so-called barcode sign, and this is therefore pleural adherence, and therefore we would withdraw the drain in this patient's case. So this is what we found in the randomized trial. If you look at the amount of the significance of the p-value, extremely significant, saving around a whole day in hospital by using the ultrasound guided procedure. So ultrasound gave us much earlier information that the pleurodesis was successful, allowed us to remove the drain and get the patient out much more quickly. And if we look at how long they stayed in hospital using standard care versus ultrasound, you can see that in the ultrasound group, on the first day, 19% of our patients left hospital. On the second day, 39%. So if you add those together, 58% of our patient population leaves within 2 days, where there's standard care, they keep going and keep going and keep going. So this is clearly an effective way of getting patients out of hospital much more quickly. But the question is, so what? If we get them out of hospital, is it helpful in other ways? Does it perhaps affect the pleurodesis, or does it perhaps increase costs? So we did both of those analyses, and you can see here that the pleurodesis success rate was not different between the two arms, and ultrasound guidance actually saves you quite a lot of money because you're saving time in hospital. And therefore, in our opinion anyway, thoracic ultrasound should definitely replace the current standard of care for MPE pleurodesis. Let me finish then quickly talk about this entity. This is an important entity, of course. This is trapped lung. What should you do if you diagnose a malignant trapped lung? You can see the incredible amount of lung trappage here, large pneumothorax with an air fluid level, and visceral pleural thickening. From a malignant case in an elderly patient, this is never going to expand, and that's why we've used an indwelling pleural catheter just here. I'll come to the BTS guidelines in a second, but we looked at the evidence for the treatment of trapped lung. There were no direct comparisons of IPC versus anything else. There were 3 retrospective case series. All of them suggested a weak evidence of benefit for IPC in trapped lung, and that's therefore what we have recommended within the guidelines. However, I would like people not to forget this as an option. So we did in fact look at, in 2023 in the guideline, at whether surgery and pleurectomy decortication was a possibility even in these patients with malignant pleural effusion. And you've got a single retrospective comparison, surgery to surgery then pleurodesis, or no surgery then pleurodesis, showing very, very different outcomes, 97% success versus 13% success. Now, these are clearly extremely selected patients with malignant effusion who have good prognosis, young perhaps, but I think we should remember that that is a treatment option. And we may have a bit more information from my Australian colleagues who are nearly complete with this exciting study called AMPLE-3. And what they're looking at here is patients with malignant pleural effusion with decent performance status, and they're randomizing them to either an IPC or a VATS pleurodesis, and that may include a decortication. So a really interesting idea that perhaps we should be going back to our roots, so to speak, and using surgery as the treatment option. We don't have results from this study as yet. Okay, I'll finish then with the BTS guideline 2023. Sorry for the typo at the top. What do? We look for patients with a confirmed diagnosis of malignant effusion. Immediately, we ask ourselves the question, will they benefit from aspiration, or rather from the intervention? And the way that we do that is do a large volume aspiration first and make sure that they feel better. And I would confine all of my definitive procedures to that group of patients. We then ask ourselves the question, can we get to the fluid? If no, then of course you just leave it. If yes, first question is the lung re-expansile? And if it is not, then your options are IPC or repeated therapeutic aspiration. I think therapeutic aspiration is a good option in patients with very limited life expectancy, which can be seen with those with non-expansile lung. If they have expansile lung, then you have 2 options. You can either go for an inpatient pleurodesis, chest tube, slurry, thoracoscopy, and poudrage, or you can go for an ambulatory strategy, that's IPC with talc perhaps in the community if they have an expansile lung. And to this guideline, I would add two things. One, don't forget surgery in the trapped lung population. And two, if you're doing an inpatient pleurodesis, then don't forget ultrasound. It seems to work very well indeed. So let me come to the end of my talk to summarize. For MPE management, there is no justification for preferring surgery or thoracoscopy over standard talc slurry pleurodesis. They're both just as effective. Sorry. Optimal pleurodesis at the bedside is a large bore tube. You can use non-steroidals. IPC and talc, there's an equipoise in terms of what you should use if there's expansile lung. If you use IPCs, I would recommend active management, so daily drainage and outpatient talc. However, you can't suggest that one is much better for quality of life than others. Ultrasound should be used for all pleurodesis, as I've suggested. And now maybe the future is that we'll be doing everything in one go. They present, we do a thoracoscopy, talc poudrage IPC, and get them home with no time in hospital. We will need the results of the tactic study to determine whether that's the way that we should be going. So I must thank all of the collaborators that I've worked with over the years who've contributed to those studies, and very many thanks for your kind attention.